everyone, respected chairpersons, colleagues, and friends. I am extremely grateful to Society of Renal Nutrition and Metabolism and its scientific committee for having bestowed this honor upon me by awarding the SRNMCON 2021. I am extremely humbled and accept it with all humility. The topic which I have chosen for this oration is micronutrients and chronic kidney disease. At the outset, I would like to pay my tribute to Professor K.S. Chud, who is father of nephrology in India and known as nationally as well as internationally as pioneer in the field of nephrology in India. I am fortunate to have a mentor like Professor K.S. Chud, and who was my teacher during my nephrology training. And whatever I am today is because of Professor K.S. Chud. And equally important, I pay my regards to my mentor, Dr. D.S. Rana, who is like my elder brother. And from PGI Chandigarh, where I came and joined Dandaram Hospital in 1987. And since then, he has mentored me and shaped my career throughout these years. I am grateful to Dr. Anita Saxena for having me in his team for building up this Society of Renal Nutrition and Metabolism since 2014. And she is a pillar behind this society. Whatever you see in the society shape today is all because of Dr. Anita Saxena. The society actually was born in 2014 when we met at Karolinska Institute in Stockholm to attend advanced renal course on renal nutrition. And then we saw this idea, myself and Dr. Anita Saxena, why can't we have our own society in India? That's how this society was planned. I will like to quote Hippocrates, which was about 400 BC. He quoted, "Let food be thy medicine and medicine be thy food." And this holds true even today. Now coming to the topic, today's topic is the micronutrients are essential for metabolic function of the body. There is a paucity of guidance regarding appropriate intake for patients with chronic kidney disease. The causes of deficiency of these nutrients are insufficient dietary intake, dietary prescriptions, dialysis procedure leading on to losses, improper absorption of vitamins, use of certain medicines, especially PPIs. One study by DOPS indicated that more than 70% of patients of maintenance hemodialysis in US take multivitamin supplements. And we don't know, in India, maybe almost 100% of patients are taking multivitamins. Insufficient evidence whether these supplements are beneficial or detrimental in these patients. Now, broadly, we have divided nutrients into two groups, micronutrients and macronutrients. Macronutrients, we all know, protein, carbohydrates, fats, and fibers, and above all, water. So we discuss these almost daily in our routine, whereas these micronutrients, which are mainly of two categories, vitamins as well as minerals, are usually not discussed so far in detail, and not most of the time in patients of CKD or dialysis patients. So micronutrients are the major group of nutrients which body needs. They are called micronutrients since they are needed in small amounts and must be obtained from food since the body cannot synthesize them. The vitamins initially were thought to be vitals and amines. That's how this word came. And vitamins are meant for energy production, immune function, and blood clotting. Whereas minerals are mainly responsible for growth, bone health, as well as fluid balance in the body. And there is another micronutrient, which is carnitine, which is especially important in patients of CKD and dialysis population. We have two kinds of vitamins. One is fat soluble, like A, D, E, and K, and water soluble vitamins, starting all the B1 vitamin to B12 vitamins and vitamin C. And as far as micronutrients in the form of minerals is concerned, we have macro minerals, which will not be discussing, like calcium, phosphorus, magnesium. And we have the trace elements, trace minerals like iron, zinc, copper, selenium, chromium, manganese, molybdenum, cobalt, fluorine, iodine, and coenzyme Q10. Now, micronutrients are required for food metabolism, energy production, cell growth, as well as immune function of the body. And in kidney disease, there is an alteration in the biochemistry as well as metabolism of these nutrients. And the nutritional requirements also changes in kidney disease. Deficiencies and abnormal high levels can occur in kidney disease. And the altered levels may impact morbidity as well as mortality if untreated. There is another problem that uremic symptoms and the deficiency symptoms sometimes overlap, and identification may be delayed. And careful assessment and appropriate interventions may lead to improvement in quality of life in these patients. The vitamins are affected by poor intake, altered taste in these patients of CKD, and various dietary restriction. This shows that as the protein intake decreases, so does the vitamin B levels in the body. And that is the most common dietary change in these patients of CKD during our practice. Vitamin status in CKD is affected by intake, that we have less of appetite, anorexia, altered change, dietary restrictions, dialysis losses, especially water-soluble vitamins, more so in high-flux dialysis, more so in peritoneal dialysis. And uremia leads on to altered metabolic pathway, and folate certain vitamins that delayed absorption, impaired absorption in late stages of the disease. Elderly population, female sets have more vitamin deficiencies, and residual renal function leads on to loss of water-soluble vitamins. Various medications like omeprazole and diuretics can interfere with the absorption. And one major, most important comorbidity is diabetes, which leads on to gastroparesis and abnormal gut function. And then body stores. It depends on the intake in the previous months or week. That also is important as far as vitamin status in CKD patients is concerned. If you see the body reserves of vitamins, B1 has a mean length of 3 to 5 years. Vitamin A has 1 to 2 years. Folic acid has 1.5 years. B2, B6, and C has 3 to 4 years. D, E, and K has 2 to 6 months, 2 to 6 weeks, and thiamine has 4 to 10 days. Lab assay of micronutrients is usually, there are problems because the serum indications concentrations are poor indicators of functional level and do not reflect the actual body stores. And another thing is that individual monitoring is very expensive in this. Once we start doing these tests, vitamins as well as trace elements, and dialysis leads on to change in the levels, high levels before dialysis and low levels after dialysis. This is just to show from our hospital that what is the usual cost of testing. Like pyridoxine level will cost around 9,000 rupees, B12 level will cost around 980 rupees, and folic acid level costs around 1,030 rupees. A and E costs 8,000 rupees. Vitamin D again costs 1,850 rupees, which we sometimes order routinely in our practice. And zinc level in the blood is 820 rupees, and copper in the is around 700 rupees. We have made a package as far as anemia profile is concerned, which consists of an iron, unsaturated iron binding capacity, transferrin, TSAT, zinc, ferritin, folic acid, as well as vitamin B12 and LDH. This costs around 4,330 rupees, but still it is not cheap. It is very costly as far as from patient point of view. Alone serum iron will cost around 410 rupees. TIBC will cost around 520 rupees. So that these two slides just show how costly this treatment, this investigation or the testing of levels is there. Now we have to see what are the red flag signs in our practice. We have to anticipate clinically, look for malnutrition, look for eating disorders, and especially patients who are alcoholics. So look for red flags in these patients. Then we have to assess the intake and go into the history of the food, what are the dietary habits, then dialysis day versus non-dialysis day, and intake when unwell, and access to the food and various cultural habits. All these affect your vitamin levels in these patients. Then, of course, we have to examine the patient and do subjective global assessment, muscle wasting, oral health, dentures, then sore throat, taste, integrity of mouth, skin, eyes, and hair and nails. This shows how various vitamin deficiencies can be diagnosed by prenatal examination. Now, recommendations as far as micronutrients is concerned, there is a lack of data and knowledge in basic vitamin and trace mineral metabolism. Limited evidence to support practice, and there are very few practical guidelines available in the literature. 2005, one guideline came, which is again obsolete and carried out of date, is out of date now. 2007 European best practice guidelines, again, and that is not accepted now. And only recently, last year, KDOQI clinical practice guideline came for nutrition by Kaiser as well as Angela Van and et al., published in American Journal of Kidney Diseases and with NKF. And I will be discussing some of these guidelines. There is evidence to support the renal-specific vitamin supplementation for dialysis patients with minimum risk, and regular multivitamin or mineral supplements, OTC products, should be discouraged in these patients. As far as KDOQI guidelines in 2020, the CKD stage 3 to 5 and post-transplant patients, it is reasonable for the nutritionist to encourage eating a diet that meets the recommended dietary allowance. That is, a recommended dietary allowance for adequate intake for all vitamins and minerals should be advised by the nutritionist in the diet. It is reasonable that if you discuss with the physician and the nephrologist and assess the dietary vitamin intake periodically and to consider supplementation with inadequate vitamin intake. And in CKD stage 5D patients, if there is an inadequate dietary intake, then it is better to supplement with multivitamins, including water-soluble vitamins and essential trace elements to prevent and or treat micronutrient deficiencies. Now, statement on folic acid. In patients stage 3 to 5D who have hyperhomocystinemia associated with kidney disease, we recommend not to routinely supplement folate with or without B complex, since there is no evidence demonstrating reduction in adverse cardiovascular outcomes, level 1A. So that shows that hyperhomocystinemia also usually is not an indication of starting folate therapy in these patients. In adults with CKD 1 to 5D and post-transplant patients, prescribing folate, vitamin B12, and B complex supplement to correct folate and vitamin B12 deficiency or insufficiency based on clinical signs and symptoms, level 2B. Vitamin C, it is reasonable to keep the levels around. Recommendation intake is of at least 90 milligram per day for men and 75 milligram per day for women. Again, this is opinion. Vitamin A and E, usually in 5D and maintenance dialysis patients, there is a potential of vitamin toxicity. So care should be taken to avoid overdose or toxicity in this population. Vitamin A usually should not be given to those patients who are on anticoagulants, for example, warfarin compounds. So these patients should not be given vitamin K supplements. Vitamin D is a very practical problem in our day-to-day practice. So we suggest prescribing vitamin D supplementation in the form of cholecalciferol or ergotasiflor to correct vitamin D deficiency or insufficiency. In stage CKD 1 to 5 with nephrotic range proteinuria, it is reasonable to supplement these patients with cholecalciferol or other safe and effective vitamin D precursors. This shows that study published in American Journal of Kidney Disease 2004 in dialysis population, they studied that mortality as well as hospitalization at patient level as well as facility level, where there was a clear-cut difference in the relative risk reduction of mortality in as well as hospitalization in patients where there was supplementation with water-soluble vitamins. We should remember, or we should have these charts available in our clinic. Recommendations for vitamin D, vitamin supplementation, starting from thiamine, B1, the riboflavin, niacin, biotin, pentothione, especially cobalamin, vitamin B12, where a normal recommended dietary intake is 2 to 2.4 milligram per day, microgram per day. And even In dialysis population, CTD stage 3 to 5 population, nephrotic range, it is still to 2.4 only. That means there is not that very high doses are required as supplementation in this population. Folic acid, which is not recommended daily intake, is 320 to 400 microgram. In hemodialysis population, it is 1 milligram per day. Ascorbic acid normally 45, but in dialysis population 3 to 5, it is 75 to 90 milligram per day. Vitamin A and E are usually not required in patients of advanced CTD and dialysis population. So A and E is usually no supplementation is required. Trace elements, trace minerals. Now coming to trace minerals in the body are less than 0.001% of total body mass. And physiological functions of trace elements are mainly concerned with oxygen binding and iron transport, mainly iron, metabolic catalysts like copper, zinc, and selenium, and various hormonal effects like selenium. Average blood concentration of biological important trace elements are substantially different in dialysis patients than healthy controls. Certain minerals have a tendency to accumulate in dialysis population like cadmium, chromium, nickel, and vanadium. Certain trace elements may accumulate like lead and copper, and probably deficient in dialysis population are manganese, selenium, and zinc. And there is insufficient information about other metals and trace elements like antimony, arsenic, boron, cobalt, iodine, mercury, molybdenum, tellurium, and thallium. Iron, we all know that there is a dysregulated iron homeostasis in CTD, and this is because of several factors which lead on to upregulation of hepcidin production. So now we have discussed iron with hepcidin as the central point. And this hepcidin reduces iron bioavailability by blocking iron absorption from blood, by blocking iron release from the reticuloendothelial system, and leads on to iron-restricted erythropoiesis. So iron itself is a big chapter, so I will not be going into the details of iron supplementation and how iron bioavailability is there in CTD and dialysis population. Certain newer treatment options for iron replacement are available now. Dialysis iron replacement like ferric pyrophosphate citrate, then oral iron replacement like ferric citrates, and we have to see what will happen once HIF, PHIs come into practice. As far as selenium and zinc is concerned, the guidelines say that we do not routinely supplement selenium and zinc since there is little evidence that it improves the nutritional, inflammatory, or micronutrient status. Although various observational studies are available in literature which show benefit with the use of selenium as well as zinc supplementation. Carnitine is very often used by clinicians, especially in dialysis population. It is an amino acid derived product, leucine and threonine amino acids. It has a role in cellular energy management, and it acts as a treatment for hypertriglyceridemia, hypercholesteremia, and anemia. So treatment for complications of dialysis like hypotension, arrhythmia, lower cardiac output state, fatigue, weaker muscle cramps, they all seem to be improving with use of carnitine, and it improves lean body mass and physical functions. The dose recommendation in dialysis is 1 to 2 grams of levocarnitine IV at the end of dialysis. There is insufficient evidence to support routine use in hemodialysis population, promising role in erythropoietin-resistant anemia. However, still there is no clear-cut guideline for the use of carnitine in dialysis patients. Why OTC supplements are not suitable for CTD patients? Because it contains some vitamins, minerals, and compounds which in excess may cause harm in CTD patients. So that's why the OTC supplements are not suitable for CTD patients. Just to share some of the medical prescriptions from our dialysis population. If you see a patient's prescription, it has injection Epofit, injection Elderwit, injection Tarnitor, and after every dialysis session, and patient is in addition to taking capsule Zavit. Another prescription shows injection NC-carb 100 mg IV every week post-dialysis 10 times, Carnishore, Methicobol, Xyrop, and Laminonefro. In addition, he is on Bitosul-Z. If you see ferrium tablet, which is very commonly used in CKD patients and dialysis population, it contains ferrous ascorbate of 100 milligram and folic acid 1.5 milligram. If you see Matilda 4, it contains a metrobelamine 1500 microgram, alpha lipid 200 milligram, folic acid 1.5 milligram, pyridoxine 3 milligram, biotin 200 microgram. And Zincovit, very commonly used, especially in corona patients. Vitamin A contains vitamin A, D, E, and zinc, which is 22 milligrams. It contains selenium, iodine, and other trace elements. Now, there was a zinc where they showed that Zincovit overuse of zinc was responsible for one of the mechanism of increased incidence of mucormycosis in COVID patients. So that means there could be some harm of overuse of zinc in these patients. This just to show that what is this amino acid solutions which we use in our dialysis population. Most of these contain various amino acids. Bitosul-Z, so commonly used, contains niacinamide 100 milligram, thiamine 10, pyridoxine 3, calcium pentothenate 50, zinc very high 41.4, biotin 100, ascorbic acid 150, vitamin B12 15, riboflavin 10 milligram. This study we did at our center, where we just analyzed the 24 hydroxy vitamin D levels in various stages of CKD. 130 patients were controls and 130 patients were of various stages of CKD and dialysis patients as well as PD patients. And our study results showed that vitamin D deficiency was equally common in control patients, almost 79.3%, whereas in CKD patients it was 88.4%. And large prevalence of vitamin D deficiency in both the groups. Vitamin D levels did not correlate with the GFR levels, irrespective of the staging of CKD, and the deficiencies was there. PD patients had greater preponderance to vitamin D deficiency as compared to hemodialysis population. We also did one study in analyze the patients over the last 3 years. Micronutrients in dialysis patients in our Tandaram hospital, and which is accepted for publication in Journal of Renal Nutrition and Metabolism. And we analyzed iron, zinc, vitamin B12, vitamin D, and folic acid levels in our dialysis population. And this showed that iron was below range in 64% of patients, zinc was low in 19% of patients, folic acid was high in 32% of patients, vitamin B12 was high in 40% of patients, and vitamin D was low in 85% of patients. So this shows that there was a vitamin B12 and folic acid were invariably high above the reference range in these patients. And iron, zinc, and vitamin D are mostly deficient among the maintenance hemodialysis patients. Vitamin supplements should be carefully prescribed, as majority of the patients had excess of vitamin B12 and folic acid rather than deficiency. Frequency of maintenance hemodialysis was not associated with any micronutrient deficiency. So to conclude, dietary intake of micronutrients is potentially modifiable factor that may have a role in the prevention of nutritional deficiency. Restriction imposed on CKD patients aiming at reducing protein, phosphate, potassium intake made it difficult to ensure adequate micronutrients content in the diet, especially when we restrict fruits, dry fruits, nuts by a blanket statement. That leads on to deficiency of various micronutrients in these patients. Supplement of water-soluble vitamins should be considered in patients on renal replacement therapy. Knowledge of micronutrient disorders in CKD is scarce. Well-designed trials investigating micronutrient status in this population of patients are needed for effective intervention and targeted for those who need. A practical point would be to give a balanced tailored diet to all patients to ensure adequate vitamin and trace minerals intake in these patients. Scarcity of evidence is reflected in current guidelines. Micronutrient education to medical staff, dialysis technicians, nurses, nephrologists, as well as their organization is required. Patients have to be educated about avoiding the use of OTC supplements and herbals. as there is a lack of awareness about what is an appropriate supplement. We have to distribute certain handouts to all the patients so that they know about OTCs and its use and abuse. Dietary prescriptions have to be individualized depending on the patient's history of dietary intake. Interaction of nephrologists with their societies, especially SRNM and pharma companies, to guide them to make single tablet with the renal specific formulation for non-dialysis as well as dialysis population, also to avoid polypill problem in these patients. And judicious use of supplementation of micronutrients may improve their outcomes. Thank you very much. Thanks for your patience.